So welcome to PCRonline on VALV 2021. My name is Didier Tchétché. I'm interventional cardiologist from Clinique Pasteur Toulouse in France. And I have the great privilege today to chat with Stefan Toggweiler from Lucerne in Switzerland. And we have a very interesting topic, Stefan, to discuss. It's about Lean TAVI, how to keep the efficiency of our TAVI programs and how to save money at the end and to have some economic value in this Lean TAVI program. So well, I would like to discuss a couple of things with you, and what we could achieve at the end of this discussion would be first to understand what the Lean TAVI practice is and what are the results from your local study. And second, how can we improve procedural efficiency and at the end make some optimization of the overall TAVI pathway for our patients, because we need to treat more patients. So we need to be efficient. And you have, I would start by saying that you have a very, very impressive results. You have shown that through your abstract. It's very impressive what you have demonstrated. And briefly, could you summarize just the study? What is your Lean TAVI study, Stefan?
Yeah, thanks, Didier, for the really nice introduction. And well, what we probably all do, or what most of us do, is this minimalistic TAVI program. So we aim for early discharge. We try to avoid general anesthesia. And the Lean TAVI is really going beyond the traditional minimalistic TAVI. So what we do is we perform TAVI without sedation. There is no anesthetist and no anesthesia nurse in the room. We also don't need an intermediate or intensive care unit. So we just look after the patient outside the cath lab. And in our hospital, as soon as we did TAVI without the anesthetist, we were also able to do same-day admission, saving one day in the hospital. And I think in parallel, as you point out, there were some procedural improvements which we can discuss later. And overall, this bundle or all these measures resulted in improved efficiency and less in the marked reduction in costs.
Yeah, and we've seen that in your abstract, and it's exactly what you've described. And what I understood is that based on the preliminary results that you've provided us with, you managed to reduce the overall hospital stay, yes, the ICU stay, the sparing some human resources in terms of anesthesia, nursing staff, and so on. But how did you achieve that? Was it a one-person initiative, or was it a more global collaborative initiative? What are the key steps that you would recommend for us?
So this is very interesting, very good question. And there is a bit short time here, but we had a clinical need before the COVID-19 pandemic because we had a scarcity in ICU and in anesthesia care. So we had to come up with a solution how to continue the TAVI program. And of course, we tried then to perform TAVI without anesthesia and without ICU. So there was a clinical need, but still, although the clinical need was there and sort of everybody agreed, it was still really difficult to establish this program. So the historical barriers in the hospitals are usually very strong, and there is many stakeholders that are involved, and they're afraid of losing influence and so on and so forth. So it was quite a tough process. But I think at the end of the day, it was important to have everybody in the boat, and everybody was involved. So it was not, as you point out, it was not a one-man show or anything like that. And we had a concept that really everybody, also the head of ICU, the head of anesthesia care, they supported this concept. And of course, there are still some patients where we do need ICU because the patients are unstable, they're emergent TAVI procedures and so on and so forth. So I think it's very important to have good friends in the hospital, and then if you have a complication, they will also be fine with that, and not everybody will point at you and say, we already knew that it's not possible to do it. So it's very important to have a good concept, everybody's involved, and then I think it's you can do it. It's possible.
So it's I guess it's I would say that this is a very strong message, and it's a great take-home message, I guess, for the audience. It requires organization and collaboration of the various stakeholders in this
Yes.
overall pathway of the patient. And I have to say, I'm wondering whether it could be applicable to other countries apart from Switzerland. And if I put it into perspective with the French healthcare system, I would say that it could be slightly difficult to avoid ICU, but we have already some experience on that with some centers in France, and it seems extremely appealing. And where you demonstrated that we reduce the overall hospital duration, but one key aspect that I would like to discuss with you is about the global safety, the overall safety for the patient, because we one of the key message most of the time is to say that we can improve efficiency, but we mustn't hamper the safety for the patient. So efficiency has to match the safety for the patient. So if we only focus, for example, on one of the most common complication of TAVI, that is a pacemaker, I guess you utilized both balloon expandable and self-expanding platforms in your Lean TAVI study. What was your policy? What was the way you managed the conduction disturbances in this Lean TAVI program?
Yeah, I think it's a very, as you say, it's safety is the most important aspect, and therefore it's important to monitor outcomes. And we have now performed more than 200 patients with the Lean TAVI pathway, but of course that's not enough for rare events. So in terms of conduction disorders, maybe severe leaks or moderate leaks, strokes, mortality, 200 patients is not enough. So I think we still have to gather more data, more experience. So in terms of pacemakers, we are a little bit more aggressive. So if you have a complete AV block, we don't wait for 3-4 days. Usually if the implantation is super high in a balloon or self-expanding valve, then we may wait. But if the implantation is not so high and if the patient has a short membranous septum, then we really go ahead and implant. Sometimes we implant the pacemaker right after the TAVI procedure. So we give protamine, and then the EP colleague comes and just implants a pacemaker. And I think otherwise, if you monitor each patient for 5-6 days, obviously you cannot have a really Lean TAVI program. And in our experience, the median duration of hospitalization dropped from 6 to 3 days. So we're now at 3 days for the all-comers population, including patients in shock or emergent procedures and patients with decompensation. So I think 3 days is not bad. But that involves that you are quite progressive with the pacemaker.
Okay, so I understand that it's quite liberal, but despite this policy, the pacemaker rate was quite low in your
yes.
and this is really impressive. So it has to do something with procedural refinements, I guess. So what techniques do you utilize procedural wise?
So of course, we started to do cusp overlap now for the self-expanding valves, and resulting in higher implantations, especially with the Evolute, but also with other valves. And we also stop all the negative traumatropic medication before TAVI, so all the beta blockers are stopped. And I think overall this helps to achieve this very low single-digit pacemaker rate.
So I have to say that this was a very nice discussion, and I have several messages that I would draw from that discussion. The first one is that definitely your strategy seems to be connected to our reality, contemporary reality, with all this COVID-19 pandemic, because we had to be quite selective at one point, but on the other hand, to be extremely efficient for our patients, the patients that were treated, just to be able to treat the ones who require the treatment, to keep a short hospital stay, to be able to treat more patients, because meanwhile we are seeing a growth in the total TAVI volume. So I think it's going to be valuable for the audience to understand what are the key steps of your Lean TAVI practice, and to see how this could be totally or partly implemented in each individual institution at each country. So it's very important, and I want to thank you for sharing your experience with us. And we also understood that contemporary practice makes sense because with the cusp overlap technique, definitely the pacemaker rate, as you just mentioned, can be a single-digit rate, and this is really matching what we see with surgery, and that should be one of the goals in contemporary practice. And I guess the final message, take-home message from my side would be organization discussion, internal discussion, just to generate a program that is fitted to the institution and that is going to help treat more patients. So thank you very much, Stefan. This was a great abstract and great discussion with you. And I wish you all a very nice PCR London Valve 2021.